Okay, welcome to Acute Kidney Injury Explained. So we are going to explain this couple of sessions. So let's dive into it. Okay, acute kidney injury is actually a very new terminology, as I will explain a bit later. Okay, otherwise, acute kidney injury, always remember the definition. Okay, it's an abrupt, that's why we say acute decline. So you are having a deteriorating function. Leading to increase in your nitrogenous substances. Okay, remember the principal nitrogenous substance in the body is urea. Okay, when you have these nitrogenous substances building up in the blood because the kidney is failing to excrete them, it is known as acute kidney injury. Okay, so the reason why I'm saying it's a fairly new terminology is that in the past we used to call it acute renal failure. Okay, and you will not be wrong to use acute renal failure. It's just that today we appreciate more of acute kidney injury, and the reason why we typically want to use acute kidney injury is that it has largely replaced the acute renal failure because it reflects the recognition that smaller decrements of kidney function that do not result necessarily in overt organ failure are of substantial clinical relevance and associated with increased morbidity and mortality. Okay, so that's why we tend to use acute kidney injury to pick up those smaller declines that do not typically cause overt dysfunction. Okay, now there are multiple criteria that we use to diagnose and to stage renal failure. Okay, so in the past we used to have what you call the rifle criteria. R for risk, okay, then I for injury, then F for failure, then L for loss, then finally end stage. So it used to be sort of a you deteriorating. First you have a risk to develop it, then you get a small injury, then you are in complete overt failure, then you have loss of kidney function, and finally you are at the end stage. Okay, we used to use this, and we still use it nowadays. Of course, eventually it got replaced by what you call an Acute trial, okay, which stands for Acute Kidney Injury Network. Okay, so it took a bunch of things from rifle, included in some new things, and made it much better. Again, you do hear it being used here and there, although currently as we speak, we mainly, if you read current articles of 2021, we are now moving on to the KIDIGO. Okay, so what you call the Kidney Disease Improving Global Outcome. Okay, so it has both a diagnostic criteria and a staging. Okay, so if you are seeing the picture now, you should be seeing that for the criteria to diagnose acute kidney injury, you either need an increase in your serum creatinine by greater than or equal to 0.3 milligram per deciliter. You'll probably be more familiar with the micromole per liter, which is 26.5, within 48 hours. Okay, remember it's an acute thing. Or you have increased in your serum creatinine to greater than or equal to 1.5 times the baseline. So assuming the patient had a prior UNA before he was in overt failure, now you're comparing it to that, okay? Which you are presuming to have occurred within the prior 7 days, okay? Or finally, if you have a urine volume of less than 0.5 mils per kg per hour, remember the normal urine output is typically between 0.5 to 1 mils per kg per hour for 6 hours. And remember the key thing here is that urinary tract obstruction or other easily reversible causes should be not part of this. Okay, the moment they say obvious reversible cause, you correct it. Okay, once you exclude that, then it becomes part of your criteria. Okay, and the disclaimer though is that before you diagnose, okay, and classify the acute kidney injury, assess and optimize volume status and exclude obstruction. Remember why you have to remove all these easily reversible causes of urinary obstruction. Okay, and here is a picture of the staging of by the KIDIGO that you can just pause and go through it. Okay, now it is important to take note that, and I'll keep stressing this, is that acute kidney injury and creatinine don't always go together. What I mean is that, remember we say the moment you see creatinine rising, you know you are dealing with acute kidney injury that has been there for a bit, okay, or it's worsening, okay, because you may have a normal creatinine in the presence of acute kidney injury, okay. That's why it's always useful to do your estimated glomerular filtration rate, okay. So please calculate the glomerular filtration rate, because creatinine doesn't always rise in early disease, okay. Now moving on to our approach to acute kidney causes, okay. This has been here for years and we still use it. It's quite useful. New articles are maybe replacing some of them, but it's really useful, especially for the undergrad, okay. So we divide acute kidney injury into pre-renal causes, renal, and post-renal causes, okay. It helps you categorize things much better. Of course, pre-renal will eventually cause renal and like that, okay. Now, number one, hypovolemic states, okay. Hypovolemic states, so you are thinking if the patient is bleeding, or you have severe vomiting, or you have diarrhea, or you have loss of plasma, especially in things like burns, or if you're in surgery, pancreatitis, or you are just excessively using diuretics. Okay, the moment you decrease hypoventilation, hypovolume, there is poor supply to the kidney and it will start failing. Okay, then you think about your causes of things that cause your cardiac output to decrease. Okay, heart failure is perhaps the most common, septic shock, very common, and pericardial tamponade. Okay, so think about such causes. Okay, then renal artery vessels. Okay, think about especially your renal artery obstruction, okay. It can cause pre-renal failure, okay. And finally, drugs, okay. Think about, remember, ACE inhibitors, please, and NSAIDs, okay. So always remember that your ACE inhibitors, the effect that they have, the negative effect, is on the efferent arteriole. They literally dilate it, okay. And finally, your NSAIDs, okay. This one have effects on your afferent. Okay, so that's useful to know for MCQ reasons, okay? But drugs like cyclosporine, tacrolimus, they are all causes of pre-renal failure. And finally, what I do want to mention here is nephrotic syndrome, okay? Nephrotic syndrome, we know it's a condition where, yes, you may have actual damage to the renal part of it, but ironically, nephrotic syndrome actually causes pre-renal failure. And the reason is, yes, you are volume overloaded, but the volume overloaded is in the peripheral edema, okay. It's a interstitial, it's not in the vessels. So in the vessels, you are actually very hypovolemic. That's one of the complications of nephrotic syndrome is hypovolemia, which can cause pre-renal failure, okay. So that's very useful to know, okay. Now moving on to our renal part of the causes, okay. They are typically grouped in four things. Either you are having a problem at your glomerular. If you're having a disease of your glomerular, think about your glomerulonephritis, especially rapidly progressive glomerulonephritis, or you are dealing with acute glomerulonephritis, or whatever can damage the glomerular. This will be one of the causes of your acute kidney injury, okay. Never forget your vascular diseases, and the principal one is probably vasculitis, okay. Vasculitis can be small, medium, or large vessel. They can cause renal failure, okay. And finally, the third is your interstitial nephritis, okay. We'll discuss that a bit later. And finally, you can have what called acute tubular necrosis, which we'll discuss very soon. That's very useful because it means that your kidneys are not able to concentrate urine effectively, especially your renal causes, and those are the causes. Okay, moving on to your post-renal. Okay, post-renal has two major groups. Okay, either you're having an extra-renal obstruction, which is beyond the kidney, or you're having an actual renal the renal pathology that is obstructing. So what are the common pre-renal obstruction? Okay, think about your prostatic enlargement. Okay, if you have urethral stenosis, if you have a tumor, or you have calculi. Okay, those are things that can cause post-renal, extra-renal obstruction. Okay, and intrarenal, think about especially uric acid crystals. Okay, uric acid crystals, we see it. There is something called sloughed papillae, okay, when you have sloughing of your papillae, or any proteins can cause a level of intrarenal obstruction. So that's very useful to know. Now, I want to mention something, okay? The main causes of post-renal failure are obstruction, okay? We can see obstruction, okay? Especially in men, the most common will be prostatic hypertrophy, okay? Especially in men. And also think about your bilateral urethral obstruction, which is caused by your abdominal or pelvic malignancy in either of the genders, okay? By far, the most common causes of obstructive nephropathy are urethral obstruction due to either you are dealing with malignancy or prostatic obstruction, okay, due to whether now it's benign hypertrophy or a malignant hypertrophy, okay. So it's useful to know what's common out in our setting, okay. Now we define acute kidney injury as the increasing your nitrogenous waste products because they are not being excreted, okay. Now firstly, let's define what is uremia and what is azotemia, okay? The moment you have high levels of urea in the blood or other nitrogenous substances, the waste products, with symptoms, it's known as uremia, okay? The moment you do have high urea or other nitrogenous substances, and it's showing biochemically, or you can see the BUN is increased. So biochemically, you can see that there is definitely increase in your urea, but there is no symptoms. So it's at a lesser degree. We call it azotemia. Okay. So with that out of the way, I want you guys to know the symptoms of uremia. Okay. They are typically very non-specific, but it's useful to group them under certain systems, okay. Cardiovascular, we always talk about what we call uremic encephalopathy, okay. So that is one of the manifestations of uremia. It can cause an encephalopathy. However, it can cause other CNS problems, especially memory issues. They tend to be very insomnic, or they have what we call diurnal somnolescence, okay. Those are other things, but never at least forget encephalopathy, okay. Cardiovascular, they actually develop what we call pericarditis, okay. We call it uremic pericarditis, okay. It's actually one of the indications for immediate hemodialysis, okay. Uremic pericarditis. However, other things, they can develop hypertension, they can develop coronary artery disease, they can develop fulminant pulmonary edema, okay. So that's useful to know, okay. Abdominal manifestation of uremia, very common, anorexia, okay. Very common, they tend to get what we call a metallic taste, okay. Never forget that, okay. They can also develop especially pruritus, okay, and they can develop stomatitis or any form of gastroparesis or nausea and vomiting, okay. So please know those. In dermatology, there's something that we call uremic frost, okay. There is a picture there, so you can see it's those whitish discoloration because of excretion of urea through the skin, which we call it uremic frost, okay. However, there are other things. Remember, pruritus is very common, okay, and other things like skin dryness are also fairly common, okay. Those are just some of the systems we've described. Remember, there are way more other systems. I mean, it can affect your hematology, it can affect your endocrine, it can affect your nutrition, it can affect your immunity, it can affect peripheral nerves in neurology, okay. So it has a lot of manifestations that you can have for uremia, and they're typically very non-specific, okay. With that out of the way, now what will be, because you would want to know from clinically just assessing the patient, you want to already have clues of, am I dealing with pre-renal, am I dealing with renal, am I dealing with post-renal, okay. Remember, the management differs a bit, particularly the cause-wise, reversing the cause. So it's useful to know which causes you'll be hunting for. So you need clues, okay. Remember, pre-renal is mostly is due to hypovolemia, okay. So you typically have low BPs, okay. So you're seeing patient has low BPs. Clinically, the patient is very volume depleted, Okay, so it's dehydrated, it appears in shock, there's poor perfusion of the peripheries, okay, or you just have a decreased urinary output, for example. And almost very important, when your urea is greater than your creatinine, and I don't mean by numbers, what I mean by ratio, okay. If it's markedly increased but creatinine seems to be fine, think about your pre-renal causes. Okay, for example, if your urea is 27, remember urea is typically 2 to 7, 2.1 to 7.1. So if your urea, for example, is 28, but your creatinine, which is anywhere between 6 to 110, is just maybe 120, I mean, you can see that from the baseline, 7 and 28 are very far. This is markedly raised as opposed to 110 and 120. So think about your pre-renal causes. Okay, so that's very useful to know. So what gives away that the patient is likely having a renal cause? Okay, remember your glomerulonephritis. Okay, these patients they can present in hypotension. Okay, they can present with proteins. Okay, and hematuria. Okay, again, those are all clues that are pointing you that maybe I'm dealing with glomerulonephritis. Okay, remember hypertension is also a common presentation with glomerulonephritis. Okay, if you're thinking of things like you see a patient has a rash, you are thinking and he is in acute failure, or you're thinking is he having an allergic reaction to something, what you call acute interstitial nephritis, okay, or the patient appears to be anemic, okay, or thrombocytopenic. Those are typically complications of renal failure, renal causes, okay, so that's useful to know. Okay, now quickly before we move on to your post-renal, I just want to highlight some key things of what acute tubular necrosis is. Remember, we have described that the lumen of kidneys have what we call epithelial cells. Okay, just go back to your anatomy and physiology video. Epithelial cells. Okay, when there is death of these tubular epithelial cells, that typically forms part of your renal tubules of your kidney, there is what we call acute tubular necrosis. Okay, because there is death of these epithelial cells that line the lumen of your tubules. Okay, now this can occur in 3 stages. Okay, number one, there is an onset. Okay, onset simply means the insult, whatever is causing which will highlight the causes very soon. So there's a cause, so that's how it starts. There's an insult to the kidney tubules. Okay, then you enter an oliguric state. Okay, what you call in oliguric phase. So this phase simply means that you are in fluid overload. Okay, you have azotemia, which is the accumulation of your blood nitrogenous substances, and of course, because you are fluid overloaded, you have a raised JVP, is typically raised. You have pulmonary edema. Okay, you have peripheral pitting edema. Okay, and etc., other forms of fluid overload. Then eventually the kidney will start recovering. You go into a diuretic phase. Okay, this is where what we call osmotic diuresis happens. Okay, so urine output starts increasing due to the fluid overload. So the kidneys want to pump out all that fluid, so you start excreting excretion of retained sodium, water, and you essentially go into what we call osmotic diuresis to pump out that thing. And finally, you have recovery. Once it has pushed out all that water and salt that was accumulated, you have recovery of your tubular function. Okay, so those are the 3 grades that you normally see of acute tubular necrosis. So what are the causes of acute tubular necrosis? Okay, very important. If you have persistent pre-renal failure, okay, let me call it persistent pre-renal hypoperfusion. Remember, one of the most common causes of pre-renal failure is hypoperfusion, okay, because of hypovolemia. When you have persistent hypoperfusion of the kidney, eventually these cells will start dying because of necrosis. There's not enough perfusion to them. Okay, so that's perhaps one of the most common causes. Okay, however, there are drugs. Okay, remember, kidneys are usually very badly affected by drugs. Think about your aminoglycoside, think about C-plastin, think about, there's a drug called amphotericin B, commonly called amphotericin, because it's so terrible to cause acute kidney injury. Okay, IV contrast, we always give it for patients going for contrasted CT scan. Okay, think about your Fostanet. Okay, those are some of the drugs that can cause acute tubular necrosis. And finally, there's something called rhabdomyolysis. Okay, hopefully we'll cover it in the endocrine video. But here, there's typically, because of your breakdown of muscle, there is what you call myoglobin that is released, and myoglobin is very nephrotoxic. Okay, it lodges into the kidneys, causing acute tubular necrosis. So the giveaway will be, you have your high CPK. Okay, your CPK will be high, and you have high potassium, you have low calcium, okay, and you have your high urea. Okay, if you are having acute kidney injury, you are seeing this electrolyte imbalance with CPK that is high, think about your rhabdomyolysis. Okay, and the final thing that we talk about in this session is your clues to your post-renal. Okay, remember, it's largely obstructive. Okay, so you ask on the history, is a history of loin pain. Okay, this is pretty common. Loin pain, patients with obstruction typically have that. Okay, is the patient anuric? Okay, because you're thinking there is an obstruction. Is there obvious hematuria? Okay, is there difficulty in urination? Especially, you can have also what you call a suprapubic mass, probably because there is urethral obstruction, the urine is being held in. Okay, you see that with a lot of obstructive problems. Okay, and typically the giveaway is typically an elderly male. So you're thinking is here having prostatic, benign prostatic hypertrophy or some kind of malignancy. Okay, or he had a recent retroperitoneal surgery. Again, this gives you clues that you're dealing more with a post-renal problem. Okay, so examine the patient. You might have a suprapubic mass. Okay, examine the rectum to see if he has a benign prostatic hypertrophy. Okay, and screen for signs of malignancy, weight loss, patient looks cachexic. Okay, that will be the end.